થેન્ક યુ એવરીવન. આઈ થિંક અત્યારે જોઈએ તો આપણે 15થી 20 મિનિટ લેટ છીએ અને પાછળના સ્પીકર છે ને એમણે મને કીધું છે કે અમારે થોડુંક લાંબુ છે, તમે ટૂંકું કરજો. So we'll try to finish my lecture in possibly 10 minutes, but it will be clinically relevant and mostly all the sentences are useful in your day-to-day practice. So I'll not go in details of investigation or pharmacodynamic, kinetic, absorption, elimination. We'll stick strictly to the clinical relevant points. What are the pharmacotherapy for obstructive airway diseases? Inhaled beta-2 agonist, inhaled corticosteroids, inhaled anticholinergic, oral short-acting beta-2 agonist, methylxanthine, PD4, and oral glucocorticoids and monoclonal antibodies. So we'll try to cover inhaled beta-2 agonist, corticosteroids and anticholinergics only, because the next lecture will be on the further treatment. So what are the goals for this treatment? It is the long-term goal of the treatment are to control the symptoms, to prevent the exacerbations, to prevent the airway damage and reduce the medicine side effects. And the aim is to achieve the best possible outcome for the patients. Ask the patient about their own goals and own preferences. As everyone knows, Amitabh Bachchan has asthma and he has to go for movies, so he has to run. So his goal is different. And if we have a patient in our clinic who has just to go to the washroom, so that goal is different. So you need to take care of these things. Patient's goal may not be the same as of yours. If you heard a word of tennis, these are the 3 different goals looking at the tennis. So what are the molecules available with the inhaled beta-2 agonist? Short acting is 4 to 6 hours, salbutamol and levosalbutamol. Long acting is 12 hours, salmeterol, formoterol and arformoterol. Ultra long acting is indacaterol and vilanterol. These are the clinically used molecule. I have not touched upon the non-used molecules. Second is the inhaled corticosteroids, is the beclomethasone dipropionate, which has effect of about 6 to 8 hours. Budesonide, fluticasone propionate and mometasone has effect of around 12 hours. And fluticasone furoate and cyclosonide both have effect of around 24 hours. And the third part is inhaled anticholinergics, antimuscarinics. Short acting around 6 to 8 hours is ipratropium, and long acting 12 to 24 hours depend upon the dose is tiotropium, umeclidinium, eclidinium and glycopyrrolate. So how will you deliver these medicines? So choice of device, dry powder inhalers. These are only appropriate if the patient can make a forceful and deep inspiration. You should check visually that patient can inhale forcefully through the device. If patient is not able to inhale forcefully, the powder will not go inside. And if there is a doubt, assess objectively. And otherwise, if he is not able to do, choose the alternate device. Second is metered dose inhaler or soft mist inhalers. It requires coordination, device triggering and inhalation. So once the patient patient has to inhale, at the same time slow and deep inhalation is required. Check visually that the patient can inhale slowly and deeply from the device. And if there is a doubt, consider adding a spacer or choose alternate device. For the patient unable to use MDI with or without spacer or DPI, a nebulizer should be considered. And other factors to consider includes the size, portability, and cost of the devices. Smart inhalers may be used if there are issues with the adherence or persistence or inhalation technique for the device that can check it. And most important is physician should prescribe only device that they know how to use, because sometimes it happens that disc healer is prescribed, and once the patient comes with the disc healer and we are not knowing how to use it. So we must know how to use it, how should patient should inspire from this, with how much force he should be inspiring. So what are the basics of appropriate inhalation device choices? How you should choose from these three devices? It is the availability of the drugs in the device. Sometimes it happens that if you have prescribed nebulizer and the drug salmeterol is not available in nebulizer, so you will not be able to prescribe that drug in nebulization. Patient's belief, satisfaction with the current and previous devices. Patient is using dry powder, and if he is satisfied, and now if you want to switch over to the inhaler, meter dose inhaler, then again you need to see whether patient's preference is towards dry powder or towards MDI. The number of different devices types should be minimized. That if the patient is using dry powder, that then as an add-on therapy, again you should add as a dry powder only, you should not use meter dose inhaler. And device type should not be switched in the absence of clinical justification, nor without proper information, education, and medical follow-ups. Shared decision making is the most appropriate strategy for inhalation device. That yes, I want to choose this device for you, you are using this device for yourself. Now we should justify each other, and then we should go whether we want to switch to the device or we will continue the same device. So it will be a shared decision by physician and patient both. Patient's cognition, dexterity, and strength must be taken into account. If a patient is bedridden, he is not able to take a deep breath, dry powder, or sometimes inhaler with a spacer may not be that much effective. In that case, even if patient wishes to have a meter dose inhaler, you have to tell them that it is better for you to go with the nebulizer. And patient's ability to perform the correct specific inhalation maneuver for that device must be assessed. So these are the points we should consider while we are choosing the device and while we are prescribing the medicines. So this is a summary of all this which I have told, that for this for the patient which is the right class of medicine, for this medicine which inhalers are currently available, which of these inhalers can be patient use correctly after training, which of these inhalers has the most or lowest environmental impact, and in the follow-up, is the patient satisfied with the medicines and the inhalers. So we have to look all these things. Now, how to decide the potency of the medicine? As per the severity score by GINA and GOLD guidelines, we need to decide which for which mild, moderate, and severe, which type of medicine we should prescribe. So the choice of inhalers in asthma, in mild cases, plain budesonide. Then if not controlled, formoterol with budesonide, salmeterol with fluticasone, and short acting for acute settings. Formoterol has a quick similar onset as a short acting beta 2 agonist. So formoterol is considered as a smart therapy. So if you have a formoterol, patient is on formoterol, then you may not need to have a levosalbutamol or salbutamol separate for that patient when the patient gets an exacerbation. Patient can take the same DPI or MDI for reliever also. In the moderate cases, you need to increase the doses for formoterol from 6 to 12, and budesonide from 200 to 400. Formoterol, fluticasone again same 6 or 12, and fluticasone 500. Formoterol 6 along with mometasone 200 and salmeterol 50 with fluticasone 500. And in severe cases, nowadays every company is coming with the triple combination. Formoterol 6, budesonide 400, and glycopyrronium 25 or 50, depending upon once a day or twice a day regimen. Vilanterol based and indacaterol based combinations are also available. They are more preferred as a once daily and more in a COPD. But in case if it is not working for formoterol based combination is not working, even you can continue with this in asthma also. So choice of inhaler for COPD: mild cases ipratropium for the acute reliever, tiotropium 9 or 18 microgram, and glycopyrronium 25 to 50 microgram as a single drug. These are the antimuscarinic agents. In moderate cases, you need to combine it with LABA, long-acting beta-2 agonist. In moderate cases, tiotropium with formoterol or glycopyrronium with formoterol. And in severe cases, again a triple drug combination is required: indacaterol or vilanterol or formoterol as a LABA, glycopyrronium or umeclidinium as a LAMA, and ICS is budesonide, fluticasone, and mometasone. There are variable combinations in the market, so you need to select according to the patient's requirement. So with this, I'll just conclude. The final pulse is select wisely as per the patient's requirement, choose a proper device as per the patient's acceptance, avoid inhaled glucocorticoids is must in the asthma and avoid in COPD unless absolutely indicated. For long-term use in moderate to severe disease, use once a daily preparation for better adherence, and escalate or de-escalate according to the clinical condition. Once the patient has improved and stabilized, you need to de-escalate, and please de-escalate in each and every case of asthma and COPD, because you may require again to be added in the future. If you do not do that, there will be a tachyphylaxis which occurs over a period of time. Thank you. So I think now we'll be able to know which is to taken from the salad.